Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, thanks for being listeners to the show. Go to dentalimplantpractices.com and find all of our resources. Also find us on Facebook, Dental Implant Practices page on Facebook, and go to iTunes and leave me a review on iTunes so we can help spread the message. Thanks. Welcome back to another episode of the Dental Implant Practices podcast. I'm your host, Philip Gordon, and today it's a huge honor for me to introduce Dr. Hilt Tatum. Dr. Tatum, thank you for being with me today.
Glad to be here, Philip.
Now, I'm in Kansas City, Missouri, and I know you're right now residing in Normandy, Paris. So I'm calling from 12 o'clock at noon.
No, not Normandy, Paris.
Or Normandy, France. My apologies.
Yes. Mm-hmm.
So you're living in Normandy, France, and I am in Kansas City, Missouri. And right now it's 12 o'clock noon my time, and it is it 7 o'clock p.m. evening time there?
It's 11 minutes after 7 my time, yes.
Okay, great. Well, I really appreciate you taking the time with me today. You are a legend in the field of implantology and dental surgery, and I would just love to try to get your story today. So I won't try to do an introduction, as I feel that it would be unmatched and unservicing. So I would love to just kind of get your story through that. And I'd love to start back kind of in the early days, when, maybe where you grew up, and then kind of walk us through your dental education, where you did your dental school, some other training after that, and then we'll kind of just keep going from there, if that's okay.
Well, that's fine. I was born in Opelika, Alabama, which is in east central Alabama, close to the Georgia line. The town I was from is adjacent to Auburn, where Auburn University is located. So it was a nice area, university and industrially developed. I was the last of 4 children, with 10 years between me and the next one. So essentially, I was reared as an only child, because the others were pretty well gone by the time I was 7 years old. I had one brother who was the closest to me, 10 years older, who became a dentist, and my father was a dentist, and then I had 2 older sisters. I was a pretty bad child. I was spoiled and reared in the war with older parents, so I wasn't a very pleasant child for them. I had a good time, but I don't think I was good for them. I went through school rather rapidly and went to Auburn University and finished it rather young, and then went to Emory University Dental School in Atlanta, where my father and brother had gone. University of Alabama was open at that time, but I did not go there. I went to Emory instead. Was youngest in my class and graduated 22, I think. So I got a very early start in dentistry, but probably was too young to take advantage of the education I had. When I started dental school, we had a number of World War II veterans and a number of Korean veterans in my class. Average age in the class was probably 26. And so I was very young for the group I was thrown with. I finished dental school in Emory and went into the service, was stationed at the Marine Hospital in Savannah, Georgia for 2 years. It was really a fine experience for me, because I was a dentist with a chief, a 4-striper, who made 1 denture a week. So he had his feet on the desk the rest of the time. He would back me up on anything that I needed, but he didn't do very much himself. I found out rather quickly that I could take care of the practice we had in most cases in a half time. on the staff in the hospital, we had a medical officer in charge, 2 general surgeons, and 2 internists, a pharmacist, the 2 dentists, 3 nurse anesthetists, and then the nursing staff, and 4 young MDs right out of internship. We all bonded well, and I was just part of the group. One of the general surgeons was relatively young and more or less bonded into our group too. When I realized that I had so much free time, I started condensing my patients. And on most days, I would spend half a day in the operating room with there were always 2 of the young MDs there. There was always 2, unless one of them was on leave or on vacation or out for some reason. So I kind of fell in and was another pair of hands. There was no formal training, but I did get a lot of exposure. Greatest thing I got was learning surgical asepsis, which was paramount in that period, with most of the people having been trained before antibiotics. So surgical asepsis was everything. And I just was another pair of hands. I scrubbed just about every kind of surgery you can imagine. And I opened some people, I closed some people, of course did nothing in its entirety, but had a lot of experience. But I knew so little about surgery, I was humiliated a few times. I'll always remember the day that I was holding a needle holder, and one of the young MDs looked over at me and in a very, very, very poor tone said something like, "Tatum, you idiot. You don't even know how to hold a needle holder." And I didn't. It was true, but oh, how it humiliated this young dentist who was there. And I can tell you, I learned how, and I haven't held it that way since. Just like when I was a child, I remember playing baseball, and nobody had ever taught me how to hold a bat. So I was holding a bat cross-handed until I learned that. So I was holding needle holders incorrectly until after that humiliation I learned, and I started looking very carefully at how everybody did everything so that I didn't show off my lack of education. But that was a really wonderful experience for me, and it has served me well throughout my career. After that, during that period, I moonlighted at night and on weekends in a private office in downtown Savannah on a high-rise building. The dentist was in the process of building a new office in a new medical arts center that was being developed across the street from the general hospital the community had. And when my service time was up, it was the same time he was going to move into this lovely new office. And he wanted me to join him and to work for him. He was a very nice person, very extroverted, and I might say a very good salesman. And he wanted to do full mouth restorative dentistry in his practice, and he was going to sell it, and I was going to do the treatment. Now, I don't know how either one of us got the idea that I knew how to do what he was thinking we were going to do, but I accepted it and tried to fulfill that. Another interesting little event. I remember I bought adjustable hinge axis face bow and articulator, and they came, and there were no instructions. I had no idea how it worked, so I had to get a skull and mount it on it to understand how it could be used. Now, your audience, Philip, will not appreciate what I'm saying here, because we're talking about 60 years ago, over 60 years ago, and dentistry was so different then from this time. In the state of Georgia at that time, I think there was probably one practitioner in the state that was doing complete full mouth dentistry, maybe a second one who was attempting to, and there was nobody in the state of Alabama. And so here I am, and Savannah was some 300 miles from nowhere, I called it, because it was on the coast and rather secluded from any other place of any size. And it was completely an untrained, undirected adventure in my trying to learn to care for the patients we were treating. We hired a technician at the same time that I started, and the restorative treatment we were going to do was going to be gold acrylics. Porcelains were not available. There was one porcelain called Permadent. It was just it was maybe I believe it was put on metal, but it looked like chiclets. It was not something you would put in anybody's mouth aesthetically. But the acrylics that were possible some of them were quite beautiful. The acrylic veneers, and that's what we were going to do. But again, the comedy of this thing was Buddy Reed, the technician that we hired, had graduated from laboratory school, but Buddy was allergic to acrylics. So he would not be able to process the acrylics. I did most of the waxing at nights, and Buddy would cast and polish and assemble. And then a technician at a lab, a man named Clarence Breckenridge, would do the veneers, and he was quite talented and did beautiful acrylic veneers. And in fact, I have records of. In fact, we're going to see you this spring, Philip, and you'll see the patient I'm talking about. I had an occasion to see the photographs of this patient. I believe it was at 47 years in service, in function, full upper restorative treatment with maybe 7 or 8 teeth left. And nobody can look at these pictures and know that these are not natural teeth, some of them, and they were gold acrylics, and it was 47 years old. So you'll find that quite interesting, and you'll remember that when I see you here in France, Philip. I mention this because Philip's going to visit with us in May of this coming year, or this year, Philip. That's correct, isn't it?
Yeah, that's correct. I'm coming out to Normandy for your week-long training event, and I'm really excited about that.
Okay, well, you will remember that when I show you this case. I look at it now, and it's just absolutely amazing that something could have been done 60 years ago. Well, it's not 60 now; it was 40. I think 47 when I got these pictures, and that it could look that nice and be that old and be gold acrylics. So you remember the story I'm telling you now. We'll talk about it then, Philip. So anyway, I did this for 2 years, and then decided I didn't want to live in Savannah. I had a strong affinity for Auburn football and for Auburn University, and my family, my father and brother practiced there. And so I went back to Alabama thinking I was throwing away a career. But I joined my brother in practice then, and he was 10 years older and much more capable than I was, but he had no background in what I was doing, full mouth treatment. And so we came together as equals, and I did the preparations and did the perio and endo, and we both worked in seating cases and finishing, and the occlusions, and probably I did most of the case presentations, but we both did that some, and we both worked together on taking impressions as a team, and we went in and out on the same patients, just seamlessly. There probably been few people in practice that have ever worked as seamlessly as we did together for 20 years there. And he was very happy doing the things he did, and I was happy with the things I did. We moved away from gold acrylics in the late 60s when Ceramco was introduced, and we also we had technician in when I went there in Alabama, and then in the 60s we added second technician, in the 70s the third one, and then I left Alabama in 79 and moved to Florida and practiced several years with Pete Dawson, Pete Roach, and then left for practice and opened my own practice in St. Petersburg. Added the fourth technician about that time, I think, and practiced there until I left Florida in the late 90s and came to France. When I fell off a horse and got hurt and had a back injury and was extremely busy and with a lot of pressures, and thought I was going to be in France for a few months and try to get well and then rejoin the fight in the U.S., but had a couple of heart attacks in the summer of 96, and thinking I was having a kidney stone, didn't get attention, so probably should have killed me, but it didn't. But the recovery was quite long, and it ended up with my wife and I deciding to stay in France and not come back to the U.S. I thought I had retired completely. My wife was French, and she had a home in France. When we decided to stay, we sold that, and we bought the home we have now, and that you'll visit next spring when you're here. I think when you're here, you can see how I fell in love with the home we have, and maybe you'll see how I fell in love with the area. It's been a lovely experience. And now, after 23 years here, I think it's 23, I have lived here longer at one time than I've ever lived anywhere in my life at one time. My Alabama life was divided in before education and after education, and my Florida life was about the same as Alabama practice life. But now I've lived here these over 20, I think it's 23 years. And I thought I had retired, but after I got back on my feet from the accident and from the heart damage, I had friends in England who had been visiting in my office in Florida periodically, and they started wanting me to come and help them some, and so I began to do that, and I realized the poor state, or I thought a poor state of education and dentistry in the UK, and the limited background in implantology. And so I started a series of programs. I had been involved in the AAID Maxi course concept since its inception, and had done yearly, had done a series of programs in St. Petersburg. So I had some background, and I had extensively done continuing education. I'd done programs in some 30, maybe 35 dental schools in the U.S., and had the occasion to speak at most of the major meetings. So I was when I was young, I was very shy before an audience, but by this time I had lost that. And so in England, I thought that I could contribute to helping the education in implantology some. And I started a course like the Maxi course. I never affiliated it with the AAID course. I should have, but I did everything myself. So it was just a lot of extra paperwork to have done, which I didn't do. And so I did. It was a week a month for 10 months a year. And maintained that until 2 years ago when I had a medical problem and stopped it, and have stopped most of the international traveling I was doing in Asia and Middle East, and around in Europe. After that, I still help with a number of the Maxi courses in the U.S. and co-direct the program Maxi course in University of Puerto Rico. So I still do that a week a month, 10 months a year, but not to the extent that I was doing before. I had a AAA procedure, aortic aneurysm procedure, to a little over 2 years ago, and that I decided it was time. I was over 80, and with a AAA, it was time to change your life some. So that's pretty well brings us up to the present. You will learn much more about our French life when you're here, Philip. But the field of implantology has been such a vital part of my life. I've left that. I hadn't even talked about that. I've just talked about my life up to this point. I guess probably I should go back and bring implantology into the discussion and tell you about my adventure and my trip through implantology. How about that?
Yeah, that's a great segue. I think that's what I was going to ask you next is where did you first hear about implants? How did you first learn about them? And then let's just start your journey through implantology. I know you said you'd practiced with your brother in Alabama. Is that where you first heard about implants? And who?
No, Philip. I attended the first program on dental implants given in a dental school in the U.S. in 1955 or 56. I think it was 56. It was given by Colonel Roy Bodine, who was a colonel in the United States Army, and he had an interest in implantology, and he gave a program at Emory, and I attended the program. I hope you're impressed.
Oh, yeah, I am.
I say that laughingly, Philip, because to be honest, I don't remember anything about that program except I attended it, and it was on subperiosteal implants and his name, and I don't think I could tell you another detail about it, but at least it introduced me to the concept of the word implants. Now, you're familiar with subperiosteal implants, aren't you?
Correct, yeah. Was that all that was available at the time?
Well, essentially, yes. Subperiosteal was the only thing that was being clinically done. And also, they mainly were for replacing for use with full dentures. There was a subperiosteal called a universal subperiosteal, which would be combined with natural teeth so that the edentulous areas would have removable appliances on them, implant supported, but they were subperiosteal in design. And most of the implants were mandibular, but there was a great attempts made through the years with maxillary subs. And at that point, when I attended that course, it didn't make any impact on me because I was not interested at that point. I was not interested in full dentures and partial dentures either. I was, in fact, in the 50s, there was no specialty that had much attraction to me and probably to a lot of other people. Oral surgery was strictly exodontia, trauma, and minimal tumors, which was not very attractive. Periodontology was gingivectomies was no knowledge of the etiology of dental disease when I was in dental education. And periodontology was simply gingivectomy. The cause of periodontal disease that I was taught was calculus, and the cause of caries was sugar. That was, now it seems so primitive, but that was the world of dentistry that I was trained in. Endodontics was endodontics, gutta percha, chloropercha, endodontics, crown and bridge. No, not crown and bridge. Prosthodontics was full and partial dentures. Crown and bridge was not a part of prosthodontics when I was in my dental education. The creme de creme and orthodontics, nobody knew what orthodontics were. It was just 150-something points of occlusion. You weren't taught much about actual orthodontics except how to refer to a practicing orthodontist. So that was a world of specialties that was available, and it didn't hold attraction too much for me. What was attractive was crown and bridge. And so that's, even at that point, that's what I was thinking about, that I wanted to do. And so the course on subperiosteals and full dentures, I listened to it, but it didn't grab me at that time. But at least that was my introduction. My real interest was whetted in 1961. My brother and I think it was 61, maybe 60, 61, 62. We were at Chicago Midwinter meeting. It would have been 62 probably. We were at Chicago Midwinter meeting and I'd been exposed in 61 to the work of Charles Bass. You know who I'm talking about when I use that name?
I do not know.
Okay. He's the father of the knowledge we have about dental disease. He was dean of the medical school at Tulane University. He was a pathologist by training. He retired in 1940 as the medical school dean. He had some dental problems that no dentist was able to help him with, and as far as treatment was concerned, or etiology. And upon his retirement, he had established a department at Tulane, and he was given the title Professor of Experimental Medicine. What it was a microscopic investigation of the etiology of dental disease. And he, though G.V. Black had written about dental disease and the microbial basis in some years past, it had not been incorporated into dental education and in clinical dental usage. So Bass determined the microbial organisms that caused caries and periodontal disease. And by 1947, he began to publish his findings. They came out simultaneous with the ADA push and the government push for fluoridated water. And Bass was announcing that dental disease, caries and periodontal disease, were caused, had a microbial basis, and that to prevent both of them, you needed to remove the microbial activity, basically have clean mouths, remove the biofilm shielded plaque on the teeth, and rid the pockets of the microbial accumulation. And that went contrary to what was being promoted in dentistry with, at that point, fluoridation was going to eliminate caries or dramatically reduce caries, and that was a push in dentistry. So the anti-fluoridation, these are not real strong groups now, Philip, but in the 50s and 60s and 40s, late 40s, 50s, 60s, 70s, the anti-fluoridationists were extremely well organized and fought the fluoridation of water in city after city or state after state. Are you aware of that? Have you encountered that? You know what I'm talking about?
I don't think it's as strong nowadays, but I'm aware that there was resistance at first.
No, it's not today. It's not today, but 40, 50 years ago, it was extremely strong. That's what I'm saying.
Yeah, no, I was unaware of that.
Okay, so Bass was quoted by the anti-fluoridationist when he began to publish and report what he had found microbially, so that nothing that he wrote was acceptable in general literature except O, the O organization would publish from him, but nothing else in dentistry would publish anything Bass wrote because he had been quoted by the anti-fluoridationist. So he published his landmark work on the etiology of dental disease, primarily in the American Medical Association Journal and the Louisiana State Medical Journal, but it was blocked. His information was largely blocked in organized dentistry. In Texas, in the 50s, at the University of Texas Dental Branch in, I forgot where, maybe it was in Austin, but it was the University of Texas Dental School. It was called Dental Branch. There was a fellow named Sumter Arnhem who was the chairman of the clinics there, head of the clinics, or maybe the restorative operative department. But Sumter was an oral pathologist by training. He had trained at Harvard, and Houston is not too far from New Orleans. Bass started offering courses, weren't courses. First off, all of the medical students at Tulane took his course on etiology of dental disease. So the medical doctors being educated at Tulane in the 40s and 50s were trained in the microbial basis of dental disease. And also, any dentist that would come and spend a week with Bass, he would one-on-one with you, train you in his laboratory using phase microscopy, and teach you about the different microbes and the binocular microscopes. It was an amazing education that you could get from him. I heard about this in 1961 at a meeting I attended, thinking it was going to be on restorative dentistry. And it was to an extent, but also Bass's material was taught in that course. It was a course given by a dentist named Bob Jones from Tulsa, Oklahoma. And Tulsa, may have been from Oklahoma City, I don't remember. But he taught the course, and it was like a religious experience for me. At that point, I had 3 children, and the 2 older ones had incipient caries on all of their proximal surfaces in the posterior teeth. I knew nothing to do about it except restore them at some point. And suddenly, I understood what dental disease was and how it could be prevented. I started taking care of my own children's teeth. I cleaned their teeth at night. Toothbrush and dental floss removed the plaque. None of my children ever had a caries restoration as long as they lived in my house till they were adults, because I cleaned their teeth properly for them. It took a minute or two a child a night. And so I was exposed to that, Bob Jones, and I immediately contacted Dr. Bass and went down and spent, in 1961, I spent a week with him, a working week, looking at his microscope. Most time in my life I've spent looking at a microscope, I'm sure. And so that became just an integral part of our practice, and healthy mouths and properly treated mouths became our goal. And I was attending a meeting in maybe 62 in Chicago. It could have been 61, but it probably was 62. And my brother was a poker player and a golfer. I worked for a living, jokingly said I worked for a living. He played golf and played poker, though that wasn't fair because he was very conscientious and worked hard when he was in the office there. But we went at that time. Have you ever attended the Midwinter meeting in Chicago, Philip?
Yeah, it's quite a deal.
Well, it was the largest dental meeting in the world back in the 60s. It was held at Conrad Hilton Hotel, which was the largest hotel in the world at that time. And we went to Conrad Hilton, and it was about 3 o'clock in the morning, and my brother was playing poker with several of the other people who attended the meeting that we were at. And I didn't play poker, but I was in the room. I was little brother. I was there. And the discussion that night around the poker table, besides playing poker, the endosteal implants were introduced into the discussion. And there was one fellow at the table. His name was Abe Weppram. He was a dentist from somewhere in Ohio. And he was talking that he thought endosteal implants had the potential to eliminate free and saddle partials. And I heard this, and my ears, I got focused and became a participant, listening and talking, learning. And it really set me on fire, and my brother too. And we researched what was available and what was being done, and didn't really think that was really fitted into our concept of dental care as we were trying to do it. But the idea really stimulated us, so we started building started to develop a dog colony. We were going to do some endosteal implant research on dogs. I chuckle when I say these things, Philip, but this was a period we went through. But as we were in the process of planning and developing the kennels that we were going to do, we realized that there wasn't anything that was being done that we would do on a dog or a patient. It was that bad at that time. So we backed off of it right at that time. But literally, I was infatuated with the idea that this might be able to be done. And so then over a period of several years, we began to become involved. I bought 2 sheets of titanium from a company called Titanium Engineering Company in Detroit, Michigan. And I got 2 of these sheets of titanium, CP. CP means commercially pure titanium. And the one sheet was 1/4 inch thick, 1 foot wide, and 4 feet long, or 3 or 4 feet long. And the other one was 3/8 of an inch thick, and a foot by either 3 or 4 feet long. And I started making implants, endosteal implants, to put in edentulous areas. and I'd make the implants shapes that would fit into the available bone, and had them designed so that there would be no undercuts or no bacterial traps around the implants. And the implants that were being done in this period, in the 60s, mid and late 60s, were being recommended that you load them completely. In 67, the blade implant concept was introduced by Harold Roberts, and Lenkow was exposed to his work, began to promote and make endosteal implants and blade implants. But I was making the individual implant for individual areas, and we were using them, and the implants that were being promoted at the time were being loaded immediately. Bridges frequently were being pre-made, then the implants would be made and fitted, the bridges fitted over them, and then the bridges attached to the implants with acrylic. It was being said that the bridges were being fused to the implants with acrylic. None of that made sense to me, because I had had enough experience, surgical experience with fractures, to know it took essentially 8 weeks for a fracture to heal. And so the implants I did, from the first one I ever placed, I was making the implants and preparing the sites for them, putting them in, and letting them heal 2 months before we would consider putting restorations, and then making the bridges to fit the implants properly without any undercuts, and where they could be cleaned properly. So that was the introduction of my implant experience. I had no contact with anybody else doing implants. In fact, I avoided in that period anybody that was involved in implant dentistry, because much of what I saw I didn't think was healthy according to what I'd learned from Dr. Bass, or that it necessarily involved the best quality of dentistry when you pre-made things and attached them with acrylic. So I was on a completely different pathway from the way implantology was developing at that period, and I had no outside contacts. I never took a course from anybody or had any direct contact until the early, maybe 1971. There was a dentist in Birmingham, Alabama, named Ford Turner, who had been an anatomy professor at the UAB Dental School, and had subsequently gone through dental school and was practicing in Birmingham. And Ford was interested in the idea of implants, and he came and visited in my office 2 or 3 times. I hadn't mentioned this, but from the early period in the early 60s, we always had an open door policy in our practice, where we were doing full mouth. When I went back to Alabama, rather quickly, we developed a large opportunity for extensive restorative dentistry. Locally, my dad died 2 years after I came back, and we had his practice, which was a very old and good general practice, but a lot of deteriorated mouths with a lot of partials and old restorations, and a couple of other dentists in the community died or retired, and we had a rather large number of accumulated patients from mature practices that we were able to do extensive restorative treatment on. And Columbus, Georgia was only 28 miles away from us. And my brother had a good friend who had a very excellent practice there. And he began to ask us to see a number of his mature patients. And our practice just exploded, the restorative practice. And at that point, there was nobody in Alabama doing anything to compare with this. And still only a couple of people in Georgia. So within just several years, our local practice was about 10% of what we did, and the rest was 90%. It was the extensive restorative dentistry. And then I began to bring the implants. I did the implants. My brother was never involved in that. And the goal was to eliminate free end saddle partials. And they worked because we let them heal properly. I had surface areas. They had many different shapes. I had screws. I had types of blade concepts. I had some looked like rockets. It was just, you were only limited by your imagination, but I was trying to create surface area within the available bone to compressively load bone. Oh, and I have mentioned that in 1969, Jack Lemmons came to University of Alabama in Birmingham on the faculty of the Biomaterials Department. He had just finished his PhD. And I met Jack, somehow I met him right after he came. And he has just been a light. He's still active at the university, professor emeritus. He was chairman of the Biomaterials Department, a third responsibility in cardiovascular, a third in orthopedics, and a third in dentistry. And for probably 20 years, Jack was the preeminent person in the world in dental implant biomaterials. And so I've had this great advantage of having a friendship with Jack and a resource of information starting back in 1969. So, and probably in 71, Ford Turner visited in the practice, and then contacted me after maybe 3 visits and told me that he wanted to start a study club on implants, and would I be a member? And I mentioned to you earlier that I was avoiding contact with implantologists at that time. And so I told him, thank you, but I'm just busy and I'm not interested. He called me again and invited me, and I gave him the same answer. And then and they gave me a third call and asked me. And on that call, he told me that Jack Lemmons was going to be a member of the group, and Jack wanted me to be a part of it. And the friendship I had developed with Jack, that was a clincher. I would have jumped at it when he told me that, even if he hadn't offered it, because I had come to appreciate Jack so much. And I've gone through the years telling this story. And about 3 or 4 years ago, I was at some meeting, and Jack was there, and I told the story in his presence. He laughed, and he said, well, I've got a story to tell to you. Ford had approached him twice, and he had refused. And then Ford told him that I was going to be in it. and wanted him to join. So that's how Ford got the hooks and got us both into his group. I tell this jokingly because it was a wonderful step for me to come into contact with other people. When I joined that group, I had done more implants than everybody in the group that he put together combined. But it brought me into contact with other people, and we started having a meeting every year, the Alabama Implant Congress, and we would meet periodically a few times during the year. We had the largest dental meeting on implants in the world for, probably 12, 15 years. We had the largest meeting in Birmingham. Have you ever heard of that, Philip?
Yeah, I have. No, I think it's pretty famous.
It was then in the 70s. It was the largest. It was a larger meeting than the AAID meeting, and it was held in Birmingham in May every year. And so that brought me into the world of implant dentistry. I still didn't join the AAID for another 10 years until, Ford was president of AAID, and Maurice Brett, and Louis Naiman, and another fellow from Huntsville. We had 4 presidents pretty much right along together, and with the friendship we had in the Alabama group, they pushed me to become a member of AAID, and I did it strictly just because they asked me to. But I should have joined it earlier, but that was my mistake. But I came into it, AAID, through them. But it was the Alabama group was extremely active, and Jack was active in it, and I was. And I stayed active with that group until I left practice, left the U.S. Last year, I had an opportunity to do a 3-day program for them. First time I had attended one of their functions since I left the U.S., but there was still a very few of the older members there. But the group we had maybe 6 or 7 presidents of the AAID out of that group. I know, let's see, it was 4, and I know 6. We may have had 7 or 7 or 8 altogether through the years. And so I grew with the exposure of other people, and I contributed to that group. I introduced bone grafting into implantology in 1970, and probably the first presentations on that were done through the Alabama group, the Alabama Implant Congress. I developed the sinus augmentation procedure in 1975, and I know the first presentation, the first formal presentation on that was that procedure was in the 1976 Alabama Implant Congress, when I reported on the cases we had done in the previous 15 months. And in fact, the original things I've done, probably all of them were introduced through that group because I was so active in it, and I would introduce them to them first, and then through the Congress that we would have every May, the bone manipulation that we'll talk about so much when I see you, I began to develop that in the 70s when we were making the individual implants, and I would try to make the sockets, the implants fit the socket as perfectly as possible. So when I would make an implant, I would also make a try-in and cast it the dimension or and sometimes slightly under the implant size, or might make 2 or 3 sizes to size a socket for an implant, so that when the implant went in, it was tight and fit very precisely. And then that led to, in the late 70s, when I was exposed to the technology of computer programmable milling, where you could write programs on computers, and then your mill would automatically make the shape that you had written the program for. I had used machines when I first started making implants. The first 1 or 2 I made were rather comical. I had this sheet of titanium, 1 foot by 4 feet, and I was using a 2000 RPM straight end piece. In the lab, I carved the first implant out of a corner of that piece of titanium. It probably took me 2 weeks to do it. I learned rather quickly that wasn't very efficient, and so progressively I began to cut the metal into smaller pieces, and I began to use different lathes and different tools to reduce mass of metal off. And then a local machine shop, I began to use them to take some of the pieces, and I would have them cut off certain parts of the metal and cut them down and get them to different sizes and shapes for me, and then I would finish them myself. And then when I found out about programmable milling, I made a number of patterns and had to make me multiple implants to those patterns. And then friends started wanting to have some of them, and that became the first titanium root form system in the world. Made it in 1978 and had FDA marketing approval on it in 81, which was some time before anything else. I know Nobel came in 83, so it was 2 years before Nobel. Probably the second system was a Straumann company made a hollow basket implant, which had FDA marketing approval sometime after mine, but it proved to not be viable. It was withdrawn from the market. It wasn't successful. And then Nobel was in 83. Jerry Niznik copied the Straumann and made the root form system. The name escapes me that he had for the first one.
Was that the Corvent?
No, I don't remember whether that was the name for the first one or not. It may have been. It was a copy of the Straumann. It was a hollow basket. It was just cylinder with some limited threads and holes cut. It was a hollow cylinder with holes in it and some threads. And the one Jerry made, he made them several different diameters, and you could cut them off to make the lengths that you wanted. And then with posts that would attach to them, I made just variety of sizes. I made thinned implants, plateau implants, and screw implants on the root forms, and blade forms for thin ridges, and then I made an implant before we had bone grafting materials. for the sinus they were plateau implants where we would crack the floor of the sinus, curette, you can imagine a posterior maxilla, and we would dig a grave. We would curette bone the length of the sinus, leaving the walls. You visualize what I'm telling you? Okay. Suppose the sinus was 3 centimeters long. We would dig a grave by digging a grave. I mean, we would curette the bone from the crest of the ridge up to the floor of the sinus. Then have a try-in the size of the implant and crack the floor of the sinus and elevate it 2, 3, 4, 5 millimeters. The floor of the sinus, like putting an elevator from the ground floor up to the second floor or the third floor. And the bone that we had curetted out, we would fill the plates of the implant that were attached to a central shaft and put bone that we'd curated up along the sides of the floor that we'd elevated and put the implants in, and then use I call the whole system a unipost system from the beginning because the post that I used would fit any of the implants. They screwed in. And so those were the different implants we made. And it predated anything else that was any other titanium root forms that were available. And so that was the implant development that we had. It was I had nothing to do with the marketing of it because a pharmaceutical company, small pharmaceutical company that I knew the principals involved, I gave them the marketing rights to made an agreement with them for marketing rights in the early 80s. And then one of the family members of the principals were put in charge of it, but turns out he had what's the word I'm trying? He had a drug problem, so was not doing anything very effectively. I think I only gave them a one shape, the fin shapes to market and I quickly realized that something was wrong. They weren't doing things as they should be done. Didn't know why at the time, but I later found out the reason. And so I think that's all that they marketed for the root forms, the fin-shaped root forms. And I withdrew from that. But then, right at that point, I took some political responsibilities. I went into the chairs of the AAID, and I was on the original board. It was organized, ABOI board. And they required I guess it was first. Yeah. It was a 9-year commitment or a 10-year commitment. Yeah, I was on it 9 years, and then so it was an overall 10-year commitment that required no commercial activity. So I was sitting on this gold mine of implant development, and I knew I probably did not recognize the magnitude of the market that was there, but I knew that there was a considerable market available and that I was preventing that from happening with me when I took that. But I thought that my contribution through the development of the board was important. So I did that, and then I went through the chairs of AAID. So I had maybe a 11 or 12 year period where I had no commercial activity limitation. It ended in 1995 in November, and I left practice in October of 95. So you didn't know anything about those things, but the Tony, and is with Tatum Surgical, and that though that existed, I had formed the company, but it was never commercial until after I left the U.S. And then Tony came with the company and has built it as it is. But we actually predated anybody else in technology, and with the broadest range of products that existed and still exist. Okay, Philip, what else would you like for me to, what have I not covered that you wanted to hear?
Well, I think you've done a pretty good job, working through those time frames. You just briefly discussed about some of the contributions you made. I know you talked about, developing the bone expansion technique, the autogenous bone graft technique. You developed the sinus lift technique. Tell me what was your inspiration for some of these discoveries, and then the sinus lift obviously being a pretty pivotal point in implant dentistry, and bone expansion. How did that all come to be? And
okay, well, I told you this would be a very long conversation. if all the, I've just hit highlights. I'll go back with implants. When I started, when we started using the implants in the 60s, and I was individually making every implant, and to make them fit well, I would make try-ins the same shape, or if it was a screw, slightly undersized for the implant that I was going to do, so I could put the implant in that either fitted perfectly, or would have space for the threads to cut, or for the fins to grasp like a fish hook. And so I made these try-ins, and I would also frequently would make 3 sizes for the try-in. I would make one that was either perfect size or slightly undersized, and then I would make a couple, consider them wedges. Consider you had a wedge that was going to be a 6 millimeter wedge at the top, and it was going to taper down to a 5 millimeter or a 4 millimeter wedge at the bottom, and it was round. Well, I would make the 6 millimeter with a taper, and then I would make a wedge with a narrower top and a narrower bottom to begin the socket. Perhaps it would be 5 or 6 millimeters wide, but maybe 3 millimeters wide at the top to start with, and come down to a very narrow wedge at the bottom. And then maybe I would make another one that was 4.5 or 5 millimeters wide at the top, and would come down to maybe 3 millimeters at the bottom. And then I would have the full size, and I would partially prepare this with burrs, and then I would put this out to force the shape to exactly the size of the wedge. And then I would enlarge it, some with burrs, and then I would use the try-in to perfect the size by compressing the bone. You with me?
Oh, yeah. Yeah, definitely.
Yeah. All right. Now, in doing this, I began to realize bone is plastic. You could compress bone and into shapes, and then I began to realize dadgum, you can expand bone. It's plastic. It's moldable. And then I began to learn how to control the expansion and to direct the expansion. For example, in most implants, if you're doing bone manipulation, you want most or all of your expansion to be to the facial wall, not to the lingual or the palatal wall. So I learned how to direct that and to control it from splitting. And I also learned that if you're going to do this, you got to keep the blood supply to the bone. You can't lift full thickness flaps. You've got to maintain the periosteum. It works like the elastic sheet that's inside of a windshield in an automobile that keeps it from fracturing. You can shatter it, but you don't break it. And the periosteum, not only does it nourish and supply the cortical bone with blood supply, but it helps hold it together. And so this was just a gradually learned skill starting in the 60s. By 1970, I had realized that bone was compressible, bone was plastic, and we could partially form sockets with bone manipulation. And I made some crude instruments that we used, and I would make these try-ins. I called them socket formers that you could tap in or have on a handle that you could use leverage to direct the force in certain direction. And so that was my evolution to learning bone manipulation. And the skills I acquired through the years. And then when I came here to France, after I had the heart attacks, I had a year recovery. But early, I could go up one step at a time, and my heart was so damaged. And one step, and then another step. So I had no stamina, but my mind was fine. And we live right here in the valley, in the Seine Valley. If you dig down 5 feet, you hit water. And so we couldn't have a wine cellar, but historically, there was a cave behind our house that went into the hillside that was a wine cellar, and it went through one of the stalls in the place for horses right behind our house. So I went into that cave and got a furniture crate and put a sheet of plywood on top of it, ran an electric line in there for power, and put an umbrella over it because water dripped. And I sat there for a year making things to occupy myself. And I thought, I've got this time, I'll try to make some instruments that are designed specifically to do what I do and be able to do them better. Now, I had no background other than dental background. I'd made implants and I'd made socket formers, and I'd modified a lot of instruments in making instruments to work with. So first things I did, I made a set of, I got some just sheets of rods, stainless steel rods, and I cut them up into pieces, and I made a set of sinus instruments. Made a set of 19 sinus instruments for elevating the sinus lining. And I sent them to I found an instrument maker and gave them to him, and he made me some instruments, and I was totally dissatisfied with what he did. I mean, the detail was so bad, and so then, though, I had him make blank instruments that were whatever length they were. I had about 2,000 blank instruments. It was 6. They were shaped down like some of the periosteal elevators, 6 millimeters wide on each end, and a handle and straight. And out of that 2,000, I made 100 sets of sinus instruments. Every one of them, I individually, if they were 6 millimeters wide, I left the end 6, but I cut them down to be curettes and put a shaft on them and made a shaft and then bent them to the shape I wanted them to be. So, I called them the white instruments were straight and universal. You might use anywhere. The yellow instruments, I've been talking so long I'm getting hoarse. The yellow was for the top of the window and the bottom of the window. The green were for distal to the window. The blue were for the mesial of the window. The reds were for buttresses in the posterior third of the sinus. The blacks were for when you had bicuspids present and you needed to go superior to the bicuspids up to the anterior of the sinus next to the nose, and the black instruments were for there. And then a periosteal elevator, and those were the 19 instruments I made. I made 100 sets of them. That's some of the hardest work I've ever done, Philip. It was dirty and dirty, but I had time, and I did it. And I sold those instruments. I made them. I wasn't working, and I made them to sell because I was unoccupied at the time, and so I deliberately was doing them a revenue source, and I made that set. But I decided this was not what I wanted to do as a career. Then I worked with several different instrument makers until I found somebody that was flexible and that would make attempts to make anything I gave them a prototype on, and they would make one back and send to me, and I would modify that until it was satisfactory and send it back to them, and then they would remake it, and when they finally made it satisfy me, then I would have them make the instruments. And I worked with several different companies until I found a company that would go all the way through and satisfy me. And so I had to make, I made altogether over 400 different devices. It seems unimaginable, but when you consider there's 19 instruments in the sinus set, the bone expansion instruments, the straight bone expansion instrument, one set maybe had 30 instruments in it, or 28 or 30, and then the offset set may have had 32 or 34 in it, and then the multiples count up to a lot of little things and multiples of instruments. So it totaled up over 400 different devices that I did during that period, and I continue almost every year. I make something to try to do something that I'm doing a little better. But when we made those, and I started using particularly the bone expansion instruments, I thought I knew how to do bone manipulation before I got those instruments, but I'd never had instruments precisely made, graduated sizes, to go up to the final dimension I wanted, like this. And it just exploded our ability to do it. And I learned that the mandible, in essence, is as plastic as the maxilla if you have the right instruments to work with. So my learning, I feel like my life of implantology is like a carousel. I got on it when I heard that first program in the 50s with a seed planted, and then I've I've taken steps on the carousel all the way along. The idea of endostyle implants in Chicago, and then the beginning of making implants, and it's been a carousel. At the time I came to France, I feel like I was about 3/4 of the way around the carousel. But then as a result of the instruments that we made of many different things, the procedures, I feel like I've completed the journey around the carousel now. In 1977, I made a slide for the first time that I remember. It said the goal of modern implantology is to accept for treatment a patient at any stage of dental disease, atrophy, or trauma, and, with general health permitting, predictably restore that patient to normal contour, comfort, function, aesthetics, and health. I identified that as our goal in 1977, maybe before, but I know at that time. And that's been a lifetime goal. I have really just completed that goal. That's by getting all the way around the carousel. There are few patients that potential is not present now. Possible, not necessary or not correct for many patients, but for the patient who desires it, it's possible. And much of it has been made possible by the instruments that we've made. And you asked me about to talk about the different things, and I've talked about the evolution of the bone manipulation, and brought it up to the present. You didn't know this was going to go so long, Philip. I don't know what you're going to do with it, because there's no way anybody's going to listen to this for all this period of time, but you'll have to see what you can do with it. I'm giving it to you. When we began to do the implants, that we were trying to eliminate free end saddle partials on really high level dental patients who had a lot of dentistry and a lot of restorative dentistry and a lot of partial dentures. And most of these people in the posterior mandible had worn partials on free end saddle areas, had worn them for a long time, and the bone loss was significant vertically. And so that was my first goal, a recognition that if we're going to treat these people with implants, we have got to create new bone. Now, it seems so simple with my limited education and limited background. We need new bone. We'll grow new bone, so we'll graft bone. And we began to prepare to do that. I had the really good fortune to have a chance meeting with a friend that I had made somewhere at a meeting a few years ago, a fellow named Frank Morgan, who lived in Los Angeles. I think he was living in Los Angeles. And Frank had tours in Vietnam as a maxillo-facial surgeon, a trauma surgeon in the Vietnam War. And it had a lot of battlefield experience. And I happened to see Frank, and this was maybe in 67, 68. I met Frank, and I was telling him what we were about to start doing. We were going to start doing autogenous bone grafting on our patients to put endostyle implants on them. He listened to me, and when I got through, he was taller than I was. He put his hands on both my shoulders and looked me in the eye. He said, "Hilt, if you try to do this, on you do the selective surgery on the patient base you've got, it will bury you. It'll destroy you. Philip, it nearly knocked me on the floor because I knew that he was experienced and that there was substance behind what he was saying. And so it totally stopped our efforts to do this. I didn't go any further with it at that point. We were ready to start. And what he was saying was, if you go in the posterior mandible, open them up, do this widely, you'll have so many complications that it will bury you. Your complications will bury you. And so it stopped us until sometime in 69, sometime during 1969, I had another oral surgeon friend that I was real close to, and has been just almost a godfather for me throughout my life. Not technically, but just as a friend. I sat next to him in dental school. He's about 8 years older than I was. And he started looking after me then, and he tried to look after me the rest of my life. When I went to his funeral about 3 years ago, it was like I'd lost my father or a brother, because he had always been there caring about me and looking after me. And this same fellow in 1969 called me. His name was Don Tillery. He was from Winter Park, Florida. And Don called me and said, Hilt, I think I found what you need. He knew I wanted to do what I wanted to do. He didn't know anything about surgery or how to do it. But he said, I think I found what you need to know. He had heard a fellow give a talk from Wichita, Kansas, and his name was Jim Alley, an oral surgeon there. And Jim had done some maybe 40 autogenous harvestings on the mandible, on the dentulous patients, autogenous harvestings and bone grafts on the dentulous mandibles with no postoperative complications. And Don told me about it, and I called Dr. Alley, and he graciously invited me and my brother to visit him. And we went to Wichita and I think it was in the summer of 69 and summer, early fall. And we spent a week with him. We saw 2 surgical cases that he did. We saw several postoperative cases. I saw one patient that was 2 years post-op, one of the earlier cases he had done. He was using ribs and harvesting a rib and then sectioning the rib and placing them on edentulous mandibles. And the patients didn't wear teeth for 6 months, and then they could have new dentures made. And he had not a single postoperative surgical complication. And there was a secret. Now, Philip, what was the secret?
They didn't get infected, maybe.
Well, that was a fact. But what was the secret that prevented? Frank Morgan told me from his experience of doing multiple bone grafts on soldiers who had been injured, and the infection rate was so great that he knew if I did it electively on the patients we were treating, the complications, he could do it on the soldiers. If they died, it was a battlefield casualty. If they got infected and it didn't work, they tried. but on my patients would have been elective, and those patients would not have accepted a significant complication rate. You see what I'm talking about?
Sure. Yeah.
Okay, so what was the secret? I'm playing a game with you now.
Yeah.
But there was a secret. So what was the secret?
The type of bone, maybe.
No, sir. That has nothing to do with it.
The suturing and flap technique, perhaps.
Well, you'd have to be more specific there. What's the secret? All right, I'll tell you what the secret was, Philip. He was doing no crestal incisions. He was making 2 vestibular incisions in the cuspid area, tunneling the whole mandible, mobilizing the tissue over the mandible, decorticating it, putting the bone in. Didn't have any screws at that time. He wasn't wiring it in. He was just fitting the bone over the mandible and then closing these vestibular incisions, which were completely away from the bone graft. They were remote incisions. He was doing these as hospital cases on edentulous mouths. The surgical asepsis was excellent. He didn't have any complications. They didn't wear dentures afterwards.
That's pretty amazing.
So, well, when I left there, what did I learn? I had learned. And I saw one patient, 2 years old, and you could not tell that patient had any bone left from the bone graft. Patient had put dentures back on. The bone had resorbed away. It appeared. So what did I learn? I learned that if you do remote incisions with good surgical asepsis and you maintain intact tissue over bone grafts, that your complication rate should be extremely low to non-existent, somewhere in that range. And also, I didn't learn this, but I thought that if we treated isolated areas of the posterior mandible where there was vertical loss, if we treated those areas and we got bone to form, which I knew would happen in 6 months from seeing his cases, and then we put endosteal implants into the bone, that the bone would not resorb away because we were loading it internally. And in fact, that was correct. So we began in, 1977, we did the first autogenous bone graft that we did using, we did ribs, and we did 4 cases using ribs, and then began to use the ilium as a source. And that was the introduction of autogenous bone grafting into implantology. Not bone grafting. Bone grafting had been done, or attempted, but it had not been used in conjunction with implants, as far as I'm aware. So that was the advent of autogenous grafting, and we would not put any load on the bone. These would be just edentulous areas, or if we did a full mandible, then the people went months without any teeth before and then when we did implants, they were endosteal implants, not full dentures put back on them. So that's the story on bone grafting. After we began to do grafting, and we were aggressive with it and did them really often. After 2 or 3 years, I had an OR in the hospital that was mine. First, I had one day a week, and then from the mid-70s until I quit autogenous harvesting in the mid-80s, I had a OR 2 days a week that was mine unless I released it. We were posting 100 cases a year for several years. That's an awful lot of bone grafting. But in the grafting we were doing, the posterior maxilla proved to be a difficult area, because if there was a large tuberosity without vertical bone loss, but the sinus had pneumatized and filled up the tuberosity, you could do an onlay bone graft, but then there was not space between the ridges to put the teeth. So that type of patient we were not able to treat, and it was perplexing to me. And in 1974, in I don't know whether it was a dream or just twilight sleep, I had the idea we were on the wrong side of the mountain, that rather than trying to build something on the top of the mountain where there would not be space for teeth, we needed to go into the mountain and, in essence, into the sinus, elevate the lining and put the bone on the inside of the sinus to create space for the implants. And it excited me on one side, and it scared the heck out of me on the other, because the sinus was such a taboo area for dentists in that period. It was ungodly, the fear that a dentist had for any sinus involvement. And I was excited with the idea, and yet I was frightened about the risk of it. And the rest of 74, I don't know when that occurred. I think it was sometime in early 74. I was making implants, and so in making implants for the posterior maxilla, I started maybe making an implant a little bit longer than it was supposed to be, and I would curette the bone out of the socket, in other words, dig a grave, and then with a tri-end, I would crack the floor of the sinus. Well, before I did that, in doing different procedures, I took the bone off and saw what the sinus lining looked like. And then, Philip, you're going to find this hard to believe now. Prepare yourself. But I got the confidence up to actually touch the lining. No lightning, no thunder, no lightning.
No electricity?
Nothing, no electricity. Nothing bad happened.
Oh, my.
Frankenstein didn't appear. And then after that, a few times, I did the maxillary implants, curetted. Suppose I had 6 millimeters of depth. I would curette 6 millimeters down to the floor of the sinus. Then I would have the tri-end that was the shape of the implant. I would go up and I would crack the floor of the sinus with it. You follow me? And then gently push that up 2, 3 millimeters, 2, 3, 4 millimeters. And you would have an elevator floor that had gone up, and you would have the lining attached to it. And you could check it and see if it was intact. You hold a patient's nose and have them blow, it would pop down in place. You follow me there?
I do, yep.
Okay. So then I know it would be intact, and so we would put the bone we'd curetted out, we would put it up and push the floor up and pat the bone out around it, so we had bone around the implant, and then we put the implant in. The implant would be threaded or thin, so it had resistance on the axial walls. And it would be limited there vertically. And so we did a number of those in 74, and I call that a sinus lift. Now, that's what we're talking about is the Summers technique that Summers discovered in 1994, I think. It was 20 years before Summers.
Gotcha.
It was BS before Summers.
Mm-hmm. Yeah.
I hadn't thought about that. That's pretty good. It's BS.
Before Summers.
But
There
I've
you
always
go.
BS. And I've always called that a sinus lift. Now, to go further with that, after several years, I realized that it was better to do that by not removing the bone down to the floor, but go in as shallow as you could, and then with a blunt instrument, compress the cancellous bone up against the sinus floor very gradually. And then by compressing it further, the cancellous bone forms a mat. It presses. You see, cancellous bone is basically calcified fibrin threads, and if you compress it gradually, it compresses into a mat, and then you compress it a little more. That mat will lift the floor of the sinus, as long as there's not a buttress there. It will lift the floor of the sinus with that mat staying intact. And so you create 2, 3, or 4 millimeters additional depth without entering the sinus. You visualize what I'm telling you?
Sure. Yeah, absolutely.
Okay. So that went on in 74. And then in February of 1975, we did the first sinus where we did a window. In this case, it was on the crest of the ridge. It was a man from South Georgia named Johnny something. And he had a large pneumatized sinus. He had a large ridge, big tuberosity that was completely hollow. And so we cut the floor of the sinus, anterior, posterior, basically the length of the sinus. It's like a long elevator. And then we lifted that, and as we lifted it up, we elevated the lining around the sides of it until we took it up maybe 15, 18 millimeters, maybe 20 millimeters, and then filled that with, and we lifted the flap from the palate over from did a partial thickness and full thickness flap from starting at the junction of the hard palate and palatal slope, made an incision and did a rectangular flap and lifted that flap and then full thickness over the crest, and then outlined the window and elevated the window, elevated the lining around the window until we got to the height we wanted. Then we filled that with autogenous bone, and then we brought the flap back over. It went into the palate. It was remote and closed. And it healed uneventfully. We got a beautiful, beautiful result. And we did several like that from the crest. But you had to have a patient that with the right anatomy to do that. And then I realized that the proper approach was going to be lateral wall for most people, because they gave you direct access to the sinus without having to remove any bone on the crest and leaving the crest intact. Then we began to use a lateral wall after several, and we presented that in May 1976 at the Alabama Implant Congress. As far as I know, that was the first major presentation I made of it, and it was report on the cases done in the previous 15, 16 months, 15, I believe. I don't remember the number of cases that had been done and reported. And so we found that was, at that point, that was most predictable place in the mouth to do bone grafting. was the sinus. Now, today, interpositional grafting with a vascularized osteotomy that we do, moving crestal bone to the correct height, and an interpositional graft there is comparable to the sinus in predictability.
Wow. Yeah, those are all amazing developments.
We did the first of those, and well, this is an interesting story. By we were doing autogenous up until 83, 84, and the cost to patients in the hospital was just escalating year by year. It was costing more and more and more. And I had done the preclinical. I'd done the surgical cases in the preclinical study for the FDA preclinical evaluation of beta tricalcium phosphate ceramic material as a graft material. The company had asked, a pharmaceutical company that owned it, Boehringer Mannheim, had asked me to do the surgical cases, and so we started working with that in 79, and it ended in 83. They got a 510K approval and stopped the PMA study. But at the same time, right in that period, 82, 83, AIDS was becoming known and recognized. And are you familiar with the Rocky Mountain Tissue Bank?
I am, yes. I've used them before.
Okay, well, let me tell you history on that. Do you know how it started?
I do not know.
Okay. Bill Hyatt, do you know who Balint Orban was?
No, I'm not familiar with that.
Well, Orban wrote the textbook on periodontology. It was a big textbook that everybody referred to in the second half of the 20th century. Orban's periodontology textbook was the Bible, and Orban was practicing in Denver, Colorado. Bill Hyatt was a periodontist in Denver and trained under Orban, and in fact practiced with Orban at the last period of Orban's life. And another periodontist in Denver was named Robert Shellhorn, Bob Shellhorn. And Bob had been had a military career, and he was a walking encyclopedia of anything, any of the literature pertaining to periodontology. In 1962, Bob Shellhorn and Bill Hyatt got a grant from the Veterans Administration to do a study using fresh, frozen human bone, not autogenous, human bone, in a study for bone grafting on periodontal defects. And the VA funded that study, and it ran up until 82, when AIDS, I think 82, when AIDS was discovered. They had to stop the study because you didn't know who had AIDS and who didn't, and what bone was contaminated and what wasn't. Now, what they did between 62 and 82, they had a technician named Ken Linfors who would harvest when a person donated their body and they died. They would take the eyes and kidneys. At that point, that's about all they were taking. And Ken Linfors would go in and harvest bone from the body in a sterile manner and put it in a solution called minimum essential medium, MEM solution. And then they would freeze it in a cryogenic freezer. Forma Scientific was the name of the company. and took it down, I think, minus 150 degrees, something like that. And it was a 3-stage compressor storage freezer. And I had met Bill Hyde in the 60s. Again, I was a younger dentist, and he was a very impressive person, and I was impressed with him, met him, liked him. And in the early 70s, Bill, somewhere I met Bill or saw him. Anyway, he knew we were doing the autogenous bone grafting. And Bill asked me, he said, if you can imagine in doing periodontal bone grafting, you use tiny little bits of bone in a pocket. They would lay flaps, curette pockets, and it would be like very little pieces of graft material into the socket, very small quantities. And Bill said, I'm curious what happens if larger quantities of our bone are used. If I furnished you some bone, would you use some? So that appealed to me. I thought, my goodness, if this works, that'll save people having to be operated if we can have a bone source. So we set up the same banking facility that they had. That's why I'm so familiar with the equipment. We had the same freezer, Pharma Scientific. And when we wanted bone for a patient, and we didn't do large numbers, but we did some. When we were going to do one of those patients, we would draw blood and send to them, and they would have it human lymphocyte antigens. They would tissue type that and type the antigens, and then we would try to get a cross match of 3 human lymphocyte antigens, a cross match of 3, as I remember it, with a donor that they had. And so for a number of patients, Bill sent us this bone. They would send it in dry ice, and then we stored it in our cryogenic freezer until we used it. And we found this worked just like autogenous bone that we were operating weekly in the hospital. So we began to harvest. When we did a bone graft for a patient, any bone that was left over, we froze it in solution. We put it in sterile containers right in the operating room, and we kept a bank for that patient so that if we needed bone in the future, we had a supply for that patient. And during this period, Bill had some bone irradiated, but at that time they were giving it 6 to 7 million rads of gamma radiation. And he irradiated some bone, which destroyed the antigenicity, so you didn't have to tissue type, you didn't have to cross match. And he used some of that and told me about it. And I know that he sent me some of that bone. I do not remember when I used it or where I used it, but I know it looked different from the other that we were using. The other was so white and clean. This was grayish looking. And I thought it was an inferior product without really evaluating it. But I did use some in the 70s. When AIDS developed, they had to stop the study, the VA study, and because of the unknown factor of AIDS. And Bill started Rocky Mountain Tissue Bank, making processing the irradiated bone and selling it. But at that point, they were giving it 2.5 to 3.5 million rads. And I remember called me and in essence said, in so many words, said, I've been furnishing you some bone for 10 years. I'd like for you to buy some bone from the bank. He started this bank as basically it was going to be a service to dentistry. It was a not-for-profit organization, and it had a blue ribbon board of directors. The people in Denver gave the money to create the bank. There was a bishop on the board, and maybe one of the Coors may have been on the board. It was a blue ribbon board, and people that had contributed money to found it. So I felt obligated to buy some of it. And at this period, I'd been doing TCP for 4 years, 3 to 4 years. And I knew TCP worked, but it was slow as a graft material. It would work in the sinus. It would work for lateral augmentation. You couldn't create height and width with it. It was not predictable there. But I knew that it would work. And in this period, the first product that came to market was dense hydroxyl apatite. I don't recall the name it was called. Mike Jarko was the man that developed it, and it was brought to market, and they hired one or two high-profile people to promote it and talk about it. I remember there being written of and described as white gold, and in fact, dense hydroxyl apatite is a very poor graft material. You don't get bone in it. But the publicity in 1983 was tremendous, and it was the first thing to market. Then bone banks started selling demineralized freeze-dried bone, and it was a periodontist in Texas named Jim Melanie that wrote extensively about that, and this was the solution to all needs, because it was osteoinductive. It had bone morphogenic proteins in it. So it was going to be the magic material to grow new bone. And I was in this world of wanting to stop autogenous harvestings with a knowledge that TCP would meet some needs, and thinking that the new material, particularly demineralized freeze-dried bone, would give us a product that would eliminate the need for autogenous harvestings. And also dense HA, I bought and used some of that. So from 84 forward, we stopped routine harvestings. And after about 2 years, we realized that our results were just extremely erratic, and nothing was computerized in my office, and I wasn't comparing apples to oranges and oranges to grapes. So I just didn't know what was happening, and I realized we had to stop and find out answers. So I set up an in-house study using the Sinus as the model, and I used certain ages, I think maybe between 50 and 65, something like that. On any patient, I did bilateral sinuses that fit the model we made. I would put one product in one side and another product in the other. The goal was to get 5 specimens of every type product. So we'd do a sinus, and 4 to 5 months later, we would do implants. And at the time we did the implants, we would label them with tetracycline declamycin and do core biopsies and do histomorphometric evaluations. I remember it cost about $300 a piece for them, which was a lot of money. to evaluate the efficacy, the effectiveness of what we were using. And I also did some irradiated bone in the study because I had used a little of it, but I had a poor opinion of it without any real basis. I had just assumed it was poor quality. And in '88, we started looking at the results. We got at least 3 results of every type of product. We got 5 of some. And amazingly, at that time to me, the irradiated bone was it averaged 37% new bone by histomorphometric evaluation. The next best product we had was demineralized freeze-dried cortical bone chips, 1 to 2 millimeter particle size, and it was 11 or 12%, 1/3 the volume of new bone that we got with irradiated cancellous. So from that point forward, that has been our graft material, and that's the history of the bank and how it came about. When I learned how effective it was, I started reporting it and talking about it. They actually sold very little bone for periodontal grafting because periodontal grafting is very, very ineffective, laying full flaps and grafting and closing the flaps. The amount of bone that was used and the results were limited. But sinus augmentation was what that bank has been built on, because it has been so effective in sinus augmentations. And Bill died in the early 90s, maybe 91 or 92. And so the bank was not for profit endeavor, and they only had 1 processing room. So they stayed busy all the time, but they had limited capacity until about 3 or 4 years ago when they went through an expansion. So now they have a much larger capacity. And have you used any of the bone blocks?
I have just ordered a couple from them, and I've got them coming up soon. So I'm looking forward to that.
Well, the way that came about in 2002 or 3, I had a patient in England that was not a candidate for autogenous harvesting, and I asked the bank if I came and took a vertebra and made a block for him, would they allow me to do it? And I went and made a block for this fellow. It was up a left posterior. It went from central to, he was missing from central to molar on one side. He'd had a childhood accident. And we put that block in there and got an absolutely gorgeous result. Lifted a flap from the palatal posterior of the palate. I lifted flap and did it, and that was the first one of those. And and then they started making the blocks, and they can't keep up with the block request. I don't think they work as effective as autogenous blocks. I'm getting so hoarse. My voice is about to give out on me here.
I get it. No, I think we've probably covered enough about.
I don't know what you can do with this long as this is.
I think we've covered enough about the history and the advancements in grafting and grafting materials and techniques and instruments. I know, based upon your knowledge, you could probably talk forever about various things. And I know that I promised you an interview with a certain amount of time, and so we may
that was
look
about 3 hours ago.
we may try to divide and conquer, and maybe come around on another talk another day about something more specific. But I think we've really come full circle on a lot of things, like you said, around the carousel. And if somebody was wanting to come learn from you, obviously you still do some teaching, so they can come see you in France, and you do some other talks at different times. So you have, through Tatum Surgical, they could probably get a hold of your lecturing schedule and find you that way. Is that correct?
Oh, yes, that's right. I direct the Mexico is in Puerto Rico. I still go there a week a month. I'm 83 years old, so you never know what tomorrow brings. But that's it. I never got to one of the most exciting things we're doing, the vascularized osteotomy, but that's a story unto itself. But it has, I think, tremendous potential as an advanced technique for the future.
Sure. Well, I'll tell you what, that'll leave us something for our next conversation. I'll do a follow-up with you, and we will nail down some topics that maybe we didn't get to today, including maybe more details about the sinus lift and the vascularized osteotomy, and some more thoughts on implant training and the future of implantology. So we'll call that one version 2. And we'll have to make that another afternoon for you, okay?
Okay, fine enough. Thank you very much.
It's been a great chance to talk with you, Dr. Tatum. I'm looking very excited to meeting you this spring at your course in Normandy, and also look forward to possibly getting in touch with you again. So I really appreciate your time and your knowledge and your contribution to dentistry. And like I said, you're a special person, and I'm just so excited to learn from you and meet you.
All right. I look forward to meeting you.
Okay.
Goodbye now.
Thank you. Bye-bye.